So, can we start now? So please take your seats. We'll start our cooperation this semester. Hi, how are you? And for this semester, I'm responsible for the whole procedure, so we'll be in touch very often. Now, you'll try to be punctual at your time you come here, okay? So that we can use our time in a meaningful way. I'll just repeat what you already know. I do not believe in studying theory, at least from the beginning. No. We'll study cases. We'll try to understand the cases, and you will help me understand them because I'm not a clinician. I'm a pathologist. And after we have studied the cases, you'll study the relevant chapter from your textbook. This will be what we do as far as your studying is concerned. You learn the cases. I've prepared the PowerPoints of all systems in the summer, so they are all uploaded. They are at your disposal. So what we do, we study the cases. You help me present the cases. I need your help because I'm not a clinician. Is that clear? Otherwise, if I were a clinician, I would tell you. I'm not a clinician. However, I believe that pathology is directly connected to clinical practice. So our concept will be primarily clinical, taking into account that from the next semester, you'll start your clinical practice. So the more you understand on clinical medicine, the better it will be for you when you study the clinical practice. I'm always supportive, as you have already understood from the past semester. However, in the past semester, it was some sort of knowing each other. Now you know me and I know you. So we won't lose time. We'll try to work efficiently on the cases and get some practical abilities, some practical knowledge. Of course, pathology will be the main topic, but it will not be the only topic. So, think what we are going to do as a doctor. Will you have a test? Most probably multiple choice questions. Is that what the patient is going to give you? Some questions, multiple choice, and choose A, B, C, A and B, neither A nor B, all correct, all wrong. No, he won't. He'll show you something, he'll tell you something, you'll examine him, you'll get all the laboratory tests, that's where I am involved, and you'll decide what's wrong with him and what are you going to do for the treatment. So, anything in the educational procedure that is close to this context is valuable. So I repeat once, you'll study the cases very carefully. All the PowerPoint archives are uploaded on your e-class. And then, after having studied the cases, you'll study the relevant chapter from your textbook. So, here, there are two siblings with familiar primary pulmonary hypertension. So, what does pulmonary hypertension mean? It means that in the pulmonary circulation, there is increased pressure. This could be due to a disease, as we'll study on the respiratory system diseases, such as obstructive lung disease. However, in this case, it's idiopathic. This increase in blood pressure is familial. So, as you understand, when there is an increase in the blood circulation in the lung, That means in the pulmonary artery and its smaller branches. What will happen? What do you think? If this pressure is increased, which part of the heart will have to try harder to send blood to the lungs? Tell me, please. Which part will become stressed? Yes, the right side. So the right side has to work more to send blood to the pulmonary circulation. So if a tissue has more work to do and has to try hard, which is the change that will happen to this tissue? Adapting to this increase of its work. Yes. Hypertrophy. So the cells in the right side of the heart will become hypertrophic. Will this solve the problem? No, it doesn't solve the problem, because if the pulmonary hypertension persists, then the right heart won't be able to work properly. So think, if the right heart, despite its hypertrophy, cannot function properly, what will happen to the patient? It's very simple and logical. What will happen to the patient if the right heart cannot send the blood to the lungs? Yes. Yes, please, repeat. So, we'll have a congestion in the circulation. And how will this become visible? How will the congestion become visible? Which vessel brings blood to the right atrium? Which vessel? Do you remember from anatomy? Which vessel brings blood to the right atrium? Yes.
The superior vena cava.
The vena cava. So, the vena cava, the superior and the other, both. The vena cava. So, they will become filled with blood, and as far as the inferior vena cava is concerned, which organ will become enlarged due to the stasis of the circulation in its vascularity? Which organ? The liver. So, if you want to understand if the liver has increased in size, okay, you can have an ultrasound. However, you'll have the clinical examination. And when you hit here in the abdomen, and the sound means that there is air, because all organs, the vast majority of organs is the stomach, the bowels, they have air. The liver does not have air, so it gives another sign. If you see that sign being the same where you should press the bowel, and you understand the difference in this, that means that the liver has enlarged. And this is its macroscopic lesion, what we see. This is the chronic passive stasis due to right heart insufficiency. Okay? So, and how is this? What does it look similar? What does it look similar? Are you fond on cooking, of cooking? There is a spice you put in the, yes, in the food. But when you go to buy it, you won't have it trimmed. You'll buy it as a whole, the whole nut. You buy it, the nutmeg, because that's what it looks like. All right? This is the nutmeg liver. And it means that there is stasis in the liver vasculature, which, by the way, comprises of two vessels that bring blood to the liver, which are these vessels which bring blood to the liver. It's the hepatic artery and portal vein. And the hepatic veins take blood. So the hepatic veins will become congested, and this congestion will be transmitted in the liver parenchyma. And it will look like this. The liver will look like this. So if this lesion persists, and which part of the liver architecture will be affected? The basic histology of the hepatic lobules has two specific sites. The portal triad, where we have the two vessels we said that bring blood to the liver, and the central vein. And all the central veins take the blood, and they have the hepatic veins, and then the inferior vena cava. So when the hepatic veins are congested, and this becomes permanent, this congestion of the hepatic veins, the liver cells will become necrotic. They won't be properly, they won't take the proper amount of blood. So they become necrotic, and some enzymes will be increased in the patient's biochemical examination of his blood. Which are these enzymes? When some liver cells are destroyed, in this context due to persistent congestion in the central veins department, they become increased. Which are these enzymes that you look on the regular biochemical check? Yes, please. Yes, the aminotransferases, when they are increased, it means that something destroys the liver cells. The other part of enzymes related to the liver function are those which tell us what do liver cells mainly produce for the digestion of food? Bile. The other two enzymes are gamma GT and ALP, where they are increased when there is some sort of preventing the bile to go to the bowel. In this case, where we have some sort of congestion in the liver, do you expect these enzymes to be increased? The cholestatic enzymes, do you expect them to be increased? There is nothing wrong with the circulation of the bile, so these two enzymes will be only mildly affected or normal. Which are the two enzymes which will be increased? The aminotransferases. All right? Yes. And another interesting part in the study of this case is this. Okay, a prominent right heart border. This is related to which reaction in the right ventricle, and it has a prominent right heart border. We already said that. Why is there a prominent right heart border? Because of hypertrophy. Excellent. The prominent pulmonary arteries, of course, are compatible with pulmonary hypertension, and we have elevated right-sided pressure, so we put a catheter in the heart, and we have elevated right-sided pressures. You see, the pressure in pulmonary artery is significantly increased. Have a look here, it's 60, 32, and compare this to the normal range. But the pulmonary arterial wedge pressure is close to normal. What does this mean? This pulmonary arterial wedge pressure shows you what the pressure is in the left atrium. So the problem is exclusively located to the right part of the heart. Why do I say that? If for some reason we had an increase in the left atrium, think of something that may cause an increase in the pressure of the left atrium. Yes? The embolus will be formed in the left heart, and it will go peripherally. Something that will increase the pressure in the left atrium. Think, it's the left atrium and the left ventricle, okay? What connects these two cavities? What connects these two cavities? The valve, the metroid valve. So if this is stenosed or insufficient, this will increase the pressure in the left atrium, and of course it will cause some sort of congestion in the pulmonary circulation. However, the problem will rise from the left part of the heart. This is not the case here. Why is it not the case? Because the pulmonary arterial wedge pressure is normal. So how if we have some sort of congestion? What do we look? We look the pressure in the pulmonary artery and the pulmonary arterial wedge pressure. Thus, we understand where the problem is. So we discussed the nutmeg appearance, the heart catheterization findings, and the gene mutations. I'm not so good in genetics, so let us read together the responsible gene for the familial primary pulmonary hypertension. That means it is not related to a disease that affected the lung. It's some sort of idiopathic, but it's not idiopathic because we know the gene, so we know the problem in these rare cases of familial. Yes, please.
The ALP and the gamma GT will be decreased or increased?
Gamma GT and ALP will be close to normal because there is no problem in the circulation of the bile.
Okay.
The problem is in the destruction of hepatocytes themselves. Okay, so the responsible gene in this case of rare familial what happened and we don't, here we are. This BMPR2 gene, yes, this is the responsible gene for these rare cases of familial pulmonary hypertension. Here we have the histologic equivalent of the macroscopic image we saw previously. So, where will be the problem? You remember where the congestion is? The question is in the veins. So, all that happens is in the center of the hepatic lobule. The lobule is the microscopic unit, functional unit of the liver parenchyma. So, we'll have congestion of the central veins, centrolobular veins, and what will be a sign of chronicity affecting this congestion? If we have congestion and liver cells are destroyed, thus aminotransferase increase, we said that. We have destruction of hepatocytes, yes. If this is permanent for a period of time, what will happen in the tissue? That we have a continuous destruction of tissue. What is the process that we have already learned from our inflammation course that will take place? Yes? Huh? Scar, yes, fibrous tissue. However, since the portal triads are not affected, the fibrous diaphragms will connect centrolobular veins. And this is why, in long-standing cases, the whole procedure leads to, if we have development of fibrous tissue in the liver, do you know how we call this? Yes? Cirrhosis. So this is cardiac cirrhosis of the liver. Why cardiac? Because the problem is in the right heart insufficiency. So those were the first cases. Now, let's have a look at this case. We have a 51-year-old man with rheumatic valvular disease. That means that something affects the valves of the heart. They have those leaflets, and they are affected, in this case, by rheumatism. It's a rheumatic fever. Yes. However, they could be affected by infection. That would be in the context of infective endocarditis. When these leaflets become filled with inflammatory cells, what is there in the cytoplasm of the inflammatory cells that makes the leaflets vulnerable? What is there in the cytoplasm of inflammatory cells which they use, because inflammatory cells are phagocytes. Phagocytes. So what is there? Who knows? And this is my job, because I did the inflammation course last semester. What is there in the cytoplasm? You can say anything. There is nothing if you are wrong. No problem. The problem is if I am wrong. That's something. But if you are wrong, it's no problem. Because that's why you came here, to learn. So you can answer wrong anytime. There is no problem to this. Okay? So think, how do they phagocytose? What is in their cytoplasm? Who can tell me? And feel free to participate in the lesson, because this is very important. The participation with such a guy like me is very important for your EQ qualities, not the IQ. I'm sure this is increased. I'm sure of that. Now we'll try with our communication to develop EQ qualities. Perhaps this is not so well developed due to the educational system. No, the multiple choice questions, all this, yes, I know. No. We'll try here and have a contact. You'll have a contact with me. I hope you like me, but that's irrelevant. You'll have a contact so to understand that here we cooperate like you are going to cooperate with the patient. Because if it is only a one-man show and you just listen passively, you become pathetic. And this won't help you in your job. It won't help. It won't help. So, what is there in, yes? Reactive oxygen species and enzymes. So, what will they do in cases of infective origin of the disease? What will they do to the leaflets? They'll make them break. And what breaks there goes and becomes an embolus. And it goes to a vessel and stops, occludes the circulation. And what will happen to the tissue that took blood from the vessel that has, the lumen of which has been occluded? Yes, what will happen? Necrosis. And how is this called? This is called an infarct. Of course, we know that all ischemic necroses are of a coagulative histologic type, except for the brain, where we have liquefactive necrosis. And if this embolus is filled with bacteria. Because let's suppose that it was an infective disease that infected the leaflets of the valves. Apart from necrosis, since we have bacteria in the embolus, which cells will predominate? Which inflammatory cells will predominate in this embolus that comes from an infected site? Which cells are responsible for eliminating the bacteria? Which cells? Which inflammatory cells? You know, remember? These are the second cells. The first cells that go out of the vessels in the inflammatory procedures. Do you remember them from the last semester? You remember? Yes, please. Which are? No problem. No problem. I have the problem because I didn't teach it well. It's not your problem. The problem is mine. If you do not know the cells, you would have no problem. It's my fault. That's why I'll do it again. I'll try and see the basic information from the last semester and revise it. No problem. You remember which cells go first? The neutrophils. And how should we say that? We have the liquefactive necrosis in the brain, some viable neutrophils, and some neutrophils which have been distracted by the toxins of the bacterium. And look what it forms. Look what is formed there in the brain. We have a cavity. You see? The cavity. And what is the liquid that is full of bacteria and neutrophils and is within the cavity? And it forms a cavity in a place of the human body where there was not such a cavity. Which is this? Excellent. This is an abscess formation, and you see that ring having to do with the vasculation. And when the abscess is formed, what does it cause to the surrounding tissue? So that, look, because we have to connect it with the clinical practice. What does it do? It has a dilated left pupil. Do you remember from anatomy which nerve is responsible for the pupil in the eye, the pupil nervation? Which nerve is this from your anatomy course? Yes, please. Which one? Third, that's right. So, what did this abscess do to the third cranial nerve? It compressed it. Because when we have a cavity filled with pus, what causes to the surrounding tissues? Have a look here at the CT. Which area is this? You see? This area? Here is the abscess. And have a look at the area. What is this? Which is related to the blown left pupil. Yes. And what other is abnormal in this CT scan? What is there that you do not see in the left side and you can see in the right side? Yes, please. The ventricles. So what happened? Due to the abscess formation, which is something that takes space, similar to a tumor. In this case, it is not a tumor. It is an abscess. However, it causes edema in surrounding tissues, similar to a tumor. And what else does it do? It displaces. It displaces the normal ventricular system, and you see that everything moves to the left. So that was a complication. Okay, we saw the abscess and the edema in the surrounding tissue, the left shift of the midline, left shift. So we hypothesized that it was bacterium that caused all this. And we said that the third cranial nerve is most probably compressed. And of course, what else could this patient develop? He could develop ipsilateral hemiparesis in case the responding artery was compressed, damage to the perforating vessels of the midbrain and the pons. The pons is the margin between the brain and the spine. The pons is bridge, all right? The bridge is the word. You know where the pons is, all right? It connects the brain and the spinal cord, okay? Yes?
What does hemiparesis mean?
That means the half part of the body does not move. Why? Because the respective vessel from the other side of the hemisphere has been compressed. Or, in cases of stroke, occluded. But this is not the case here, all right? Here is everything that happens to the blood supply of the brain is due to compression because of the abscess. And why are antibiotics not efficient? Because when an abscess is formed, all the pus and the bacteria are in the cavity. We have the surrounding rim with the vessels. However, the antibiotics do not reach the pus. They go peripherally. So they are not efficient to treat the abscess. Of course, sometimes a surgical procedure is mandatory. In the present case, you see that the patient died, and have a look here. The left medial temporal lobe herniates. You remember we said in the central nervous system, the herniation, what it means, the displacement of parts of the brain, which increases endocranial pressure. Right? This is herniation. And you see here that it herniates beneath the tentorium and presses on the midbrain. The tentorium is a fold of, like the meninges have folds. This is the tentorium which separates the cerebellum from the cerebrum. This is the tentorium, So, and of course we have vasodilation due to inflammation, and the edema, leakage of fluid into the interstitium. Vascular permeability is increased by all these chemotactic factors that we have discussed in the previous semester. And this is how inflammation begins. We have the retraction of the endothelial cells, and so the content of the vessel, the blood, comes out of the vessel. And of course, edema is most attributed to plasma exudation. However, there are other cells that come out, as we have already discussed. Now, this is an autopsy specimen from a woman who had an intermittent 1-year history of sudden onset dyspnea and chest pain with tachycardia. 3 days before admission, her laboratory studies showed increased D-dimer. When are D-dimer increased? Which procedure has started and we find D-dimers increase? These increased when the procedure of fibrinolysis is set on. And so when we have fibrinolysis, what had happened what has happened prior to the fibrinolysis, so that it makes it start and we detect the D-dimers in the blood. So in order that fibrinolysis is set on, previously what has happened? Yes, please. That's excellent. We have a thrombus. All right? So when we find this in the serum, the D-dimers, we think that a thrombus has developed in some place, and fibrinolysis has started, and we have the D-dimer. So the platelet counts which could be responsible from thrombi formation are normal, and the coagulation time, prothrombin time, and partial thromboplastin time are normal. So it's a problem of a thrombus. She dies, and here is the autopsy. So let's have a look. What is the lesion on the macroscopic level? What is the lesion in this lung? Where is the lesion? Which is the border you see down, where you have the arrowhead, which is the membrane that covers the lung. It has two layers. This is the one that is attached to the lung parenchyma. The parietal, yes, of, yes, what would you call this? Pleura, all right? So it affects peripherally, and it's most like wedge-shaped, and what color is it? What color is it? It's brown. That means that in this area, blood has come. When we previously found that there was a thrombus that was formed. That's why the D-dimers were detectable at increased levels. So in order that some part of the lung is infarcted, necrotic, which vessel was occluded by the thrombus? Which vessel was occluded so that part of the lung becomes necrotic? Where did the thrombus go? Where did it go? Which part? Which vessel was occluded? Yes? The pulmonary artery. So the thrombus occluded the pulmonary artery. However, regarding the anatomy of the pulmonary vasculatures, there are two types of vessel that give blood to the lung. Which are they? The pulmonary artery and its branches, and which other independent source of vasculature do you remember? You remember? The bronchial arteries. So the bronchial arteries provided some blood, but it was insufficient to prevent the infarction. But that's why the infarct is hemorrhagic, because there was another source giving blood to the area. It did not prevent necrosis. However, it made it brown, hemorrhagic. Could this happen in the kidney? If the thrombus was formed in the renal artery and some part of the kidney was infarcted and became necrotic, would it have the same appearance? No. Why? Because in the kidney, renal arteries are terminal arteries. That means there is no other way that blood will reach the renal parenchyma. So in cases where we have an occlusion in a vein or an occlusion in an artery which have collateral vasculatures, then the infarct becomes hemorrhagic. In other cases, such as the kidney and the heart, most often, in the heart, the infarct is pale, pale, the pale infarct. That means arterial occlusion with no collateral circulation makes it pale. So, the gross morphologic, yes, the cause, the pre-mortem laboratory findings. We discussed the significance of looking for D-dimers in any patient with chest pain, all right? And dyspnea, the hemorrhagic, the red infarct, the positive D-dimer test, and it was a very large saddle embolus, blocked all pulmonary artery outflows. And why was that here? 1 year history of episodes of dyspnea? Because in the past, there were smaller thrombi, smaller, which occluded small branches of the pulmonary artery, and so the symptoms were not so abrupt. There was a history of embolism, pulmonary embolisms, in small vessels, in small parts of the pulmonary artery, because this patient had thrombosis in her blood. So, yes, please.
We said before this could not happen in the kidney. How come?
How can it happen? Think that there is a thrombus after an infarct of the heart, because the blood cannot leave the heart, it does not move, the wall does not move, and it makes a thrombus. The thrombus leaves, goes to the aorta, and when the aorta gives the branch of the renal artery, the thrombus comes in the renal artery, and we have occlusion. So, we have coagulative necrosis, but it looks pale. Why? Because there is no other way that blood comes to the area. The arteries in the kidney are terminal arteries. So those were the cases for today, and I think that we'll continue our study of cases on Friday. So. If you would like to sign for your presence, the papers are here, the seats are here, okay? In other case, there's no problem. I see, you have a problem. The others who do not have a problem are late. So why do you apologize? No problem, no problem.